Kia ora everyone, this is almost everything you'll need to know about the joints of the lower limb. The joints of the lower limb, particularly the knee and ankle joints, tend to be more relevant clinically to us. We'll start by looking at the hip joint, which doesn't tend to cause too many problems because it is such a stable joint. It's a ball and socket joint, but unlike the shoulder, the ball of the hip joint is set deep within the socket, the acetabulum, and it's reinforced by very strong ligaments. There are 3 of them, and they each arise from one of the parts of the hip bone. So we have a pubofemoral ligament here, an iliofemoral ligament here, and mostly hidden posteriorly, an ischiofemoral ligament here. The iliofemoral ligament is considered the most interesting. Its femoral attachment is along the intertrochanteric line here, and its fibers are arranged in such a way that they are twisted at rest, and when the hip is extended they tighten and tend to screw in the head of the femur more tightly into the acetabulum, so increasing the stability of the joint in extension and reducing its range of movement. We'll have a quick look at a posterior view. Here we can see the ischiofemoral ligament, and it's notable for having this inferior free edge which enables blood vessels from the medial circumflex femoral artery to slip underneath the ligament and gain access to the neck and head of the femur so that it can supply blood to those structures. Anatomists love a free edge. It gives them something to hang on to, in much the same way that Lord Flashheart likes a beard on a bridesmaid. We'll turn now to the knee joint. Here it is in its most basic form, and as you can see from the skeletal elements alone, there's very little bony stability provided to the joint. In fact, I think your book describes the bony architecture as being like 2 large balls sitting on a slightly warped tabletop, so do with that mental image as you will, but the point is that the knee depends almost entirely on ligamentous and musculotendinous structures to provide its stability. So we have this arrangement with the ligaments and some of the tendons shown. Also shown here are several of the bursae around the knee. Because there are layers of skin, tendons and ligaments, there are many bursae to help facilitate smooth movement of these structures over one another. There are 2 superficial bursae shown here, the superficial prepatellar bursa and the superficial infrapatellar bursa. They sit just underneath the skin and help facilitate movement of the skin over the joint. There is also a subtendinous or deeper infrapatellar bursa here, and also not shown a deeper prepatellar bursa, which would be behind the patella. And this is also a deep bursa here. This is the anserine bursa, which underlies the combined tendons of sartorius, gracilis, and semitendinosus, which form the pes anserinus here. Another large deep bursa, which is hidden from view here, but if we rotate the knee to look at it from medially, we can see here the suprapatellar bursa. This is important clinically because it communicates freely with the synovial joint cavity of the knee. So the bursa itself is an extension, almost a herniation of the synovial cavity through the fibrous joint capsule, and therefore any process which causes an effusion of some sort in the knee will cause the suprapatellar bursa to become filled with that same fluid. Turning now to the ligaments, there are 5 extracapsular ligaments of the knee joint, external to the fibrous joint capsule, which is the structure shown here in blue. There's 1 ligament anteriorly, 1 on each side, medially and laterally, and 2 posteriorly. We see here the anterior ligament, which is the patellar ligament connecting the named large sesamoid bone, the patella here, to the tibial tuberosity. Nearly as important for stability of the knee as the patellar ligament itself are these expansions, which are the retinacular fibers, or patellar retinacular, both medially and laterally, arising from the patellar ligament, the patella itself, and also the distal parts of the quadriceps tendon. And these retinacular fibers help to steady the knee anteriorly, so don't forget about them. Medially, just for orientation, Here is the patella, the medial retinacular fibers, and this is the medial collateral or tibial collateral ligament of the knee. It is a very long, broad, flat band. It actually is attached to the medial meniscus, one of the intracapsular ligaments, at about its midpoint. It's said to be weaker because it is damaged more often, because it is vulnerable to valgus injuries of the knee, particularly in tackle sports, where a blow to the outside of the knee with the foot planted, the medial collateral ligament tends to be stretched and can be torn. The medial collateral ligament is closely associated with the tendon of semimembranosus muscle here. Laterally, we have the fibular collateral ligament or lateral collateral ligament of the knee here, which is a much shorter, more rounded cord-like structure than the flat, broad medial collateral ligament. It's prone to less stretching trauma because of the difficulty in applying a varus injury to the knee. The lateral collateral ligament is closely associated with the tendon of the popliteus muscle, which is a structure here, and also with one of the posterior ligaments which arises from the head of the fibula, which is this structure here, which is the arcuate popliteal ligament, which we'll look at from posteriorly. This is the arcuate popliteal ligament here arising from the head of the fibula. We can't see the fibular collateral or lateral collateral ligament anymore. The arcuate popliteal ligament arises from the head of the fibula and extends superiorly overlying the tendon of popliteus and attaches to the fibrous capsule overlying the lateral condyle of the femur posteriorly. Also attaching here is this expansion from the semimembranosus tendon, which projects obliquely across the knee joint, across the intercondylar part of the knee posteriorly, and this is the oblique popliteal ligament. So the two posterior extracapsular ligaments are the arcuate and oblique popliteal ligament, the arcuate arising from the head of the fibula and the oblique arising from the semimembranosus tendon. So those were the 5 extracapsular ligaments, just to summarize: 1 anteriorly, 1 laterally, 1 medially, and 2 posteriorly, or related to the popliteal fossa. And they were the patellar ligament plus the retinacular fibers, the fibular collateral ligament, the tibial collateral ligament, and the oblique and arcuate popliteal ligaments. Now we'll look at the 4 intracapsular ligaments. These are within the joint capsule, so they're not visible from the outside unless you remove the joint capsule. And they are simply the 2 menisci, medial and lateral, different colours, and the 2 cruciate ligaments, anterior and posterior. And here with the joint capsule removed, we can see them: the lateral meniscus on the fibular side, the medial meniscus, and we can see the posterior cruciate ligament here. This little guy is the posterior menisco-femoral ligament, which exists, but we won't talk about it anymore. From the anterior perspective, the menisci are again evident. This is the transverse ligament of the knee, which again we'll not speak of, and we can just see the anterior cruciate ligament here. If we flex the knee, the anterior cruciate becomes much more visible, but I can't do that with this app. It's static. We can, however, remove the femur, and here it's worth noting that the lateral meniscus is a very closed C shape. It's almost an O shape, with the attachment points near the tibial spine very close together, whereas the medial meniscus is a much more open shape, more of a horseshoe than a C shape really. And its attachment points are widely spaced and encompass the attachment points of the lateral meniscus. The anterior cruciate ligament extends from the anterior intercondylar area of the tibia, posteriorly and a little laterally towards the lateral condyle of the femur, and the posterior cruciate ligament extends from the posterior intercondylar area on the tibia anteriorly and medially towards the medial condyle of the femur, so that the cruciate ligaments are named for their attachments on the tibia, the more distal attachment sites. If you'd like to try to remember, well, you probably don't have to, the attachment sites on the femur for each of the cruciates. You can remember anterior cruciate attaches to the lateral condyle. The posterior cruciate attaches to the medial. And if we get rid of the unnecessary letters, we have AXL, which reminds us of our friend Axl Rose once more. Here he is. And here he is with his chums in the band. And PXM, which of course is a 3-letter acronym for Product Experience Management, which is this. And here's what I think AXL thinks of PXM. Actually, that's just what I think of PXM. Once again, living vicariously through Axl Rose. And I tried living vicariously through Slash, but it didn't turn out so well. He plays good. If we view things from the side here, we can indulge ourselves with a clinical pearl. We can see that it is the anterior cruciate ligament, which when anchored here to the femur, prevents anterior movement of the tibia relative to the femur. So it's the anterior cruciate that prevents anterior draw, or prevents the tibia from being drawn anteriorly relative to the femur, which is to say that if the anterior cruciate is ruptured, then the tibia will be able to be drawn anterior relative to the femur, and the patient will have a positive anterior draw test. Likewise, it is the posterior cruciate ligament, which when anchored here to the femur prevents posterior movement of the tibia relative to the femur, and so in the case of a posterior cruciate rupture, this movement is permitted and the patient will have a positive posterior sag test. Finally, onto the ankle. We'll start with a lateral view here, and the ankle laterally is supported by 3 ligaments: an anterior talofibular ligament connecting the fibula to the talus, a posterior talofibular ligament doing the same, and a calcaneofibular ligament. So fairly straightforward. On the medial aspect, the arrangement is actually quite similar, except we have the tibia instead of the fibula. So we have a posterior tibio-talar ligament, an anterior tibio-talar ligament, and a tibio-calcaneal ligament in exactly the same way as we had on the lateral side. There is, however, one additional ligament, which is the tibio-navicular ligament here. So the names of the other 3 ligaments are just the same as laterally. They've just changed tibia to fibula and switched the words around to make them easier to say. So talofibula becomes tibio-talar, for example. The only other thing to note is because on the medial aspect these ligaments are all quite broad and run edge to edge more or less, they are known collectively by their shape as a triangle as the deltoid ligament, but it consists of those 4 parts. While we're in this view, we can see here the very nice short plantar ligament, or plantar calcaneocuboid ligament, and also the long plantar ligament, which is also a calcaneocuboid ligament, but has fibers which extend towards the metatarsals and cuneiforms and provide a bridge over the groove in the cuboid for the tendon of fibularis longus, that most excellent of tendons. The structure here is the plantar aponeurosis, which is relatively superficial. And we can also see here the quite lovely spring ligament, or plantar calcaneonavicular ligament, which extends from the sustentaculum talo of the calcaneus to the tuberosity of the navicular and supports the head of the talus inferiorly, where otherwise it would be exposed. So that's all you need to know about the joints of the lower limb, or almost. Of course, for more detail, you should consult your textbook. That really is the last video on the lower limb, and it was a bonus one. Next time we'll head off to the head and neck. Until then, ka kite.